Hello, everyone, and welcome. My name is Miriam Elford, and I'm happy to be here today to talk to you about my research, which examine the impact of a support group on fathers' stress, depression, coping, and marital satisfaction. And just to give a little bit of background information about me, I've worked in the field of autism and special needs, developmental disabilities for, let me think for a second, about 23 years now in a variety of roles. And I currently work in a few different roles. So one of my responsibilities is as a program manager and a consultant at the Reach Child and Youth Development Society, which is in Delta, British Columbia in Canada. And there I work on a multidisciplinary team. So I work together in collaboration and fairly close consultation with speech language pathologists, with occupational therapists, with a variety of different service providers to provide intervention to children with autism and also consultation and support to their families. I'm also an instructor at one of our local universities, and so I teach classes in our applied behavior analysis undergraduate program. And this research came out of my doctoral work. So this was research that I did for my doctoral degree. So it's a topic that I'm very interested in and passionate about, and hopefully that will come across, and I will be sharing maybe some new information with you, and certainly keen to hear your feedback or answer questions. I know that we're trying to sort of save questions until the end, so if you do have them, and hopefully that is all right and acceptable to save them to the end, and we can have hopefully some discussion at the end of the talk. So in looking at, the first thing I'm going to show you is a couple of quotations, and this is in looking at the research that has been conducted on fathers. These quotations are separated by almost 55 years, and this provides a backdrop for this research that I'm going to talk about, my research today. And the first quotation is from a paper entitled The Fathers of Autistic Children, and it was written by Leon Eisenberg, a prominent child psychiatrist who, hang on, just close in case anybody heard that or that was just coming through my microphone to make sure that I'm not interrupted. And so Leon Eisenberg wrote this paper, and he describes sort of the personality characteristics of fathers of children with autism, and he uses 3 case studies that he gives as particular examples. So Eisenberg says, the psychiatric literature is rife with studies of childhood disabilities in which detailed and particular attention is given to personality traits in the mother, presumed relevant to the disorder in her child. Father has been the forgotten man. And this other quotation I'm going to show you is from 2011. And in this systematic review that the researchers conducted, they concluded that despite their important and unique interaction styles, language, and play models, fathers are largely overlooked in our current ASD research. Even in today's world of increased co-parenting by fathers, participants in parent studies in ASD are almost exclusively mothers. So Leon Eisenberg's lament about fathers as the forgotten man was really sort of echoed in a systematic review in 2011 in looking at research today. I was just talking a moment ago before we started recording that I was reading an article from earlier this year, and essentially the conclusion is the same, that fathers are underrepresented. And in this 2019 review that I read, they talked about this really being alarming, considering recommendations that fathers become more involved in early intervention and therapeutic efforts, whether it's parent-mediated interventions or parent training-based interventions, and that research has found that there are positive outcomes when both parents are involved. So for all of these reasons, I'm going to get into those reasons a bit more, but the bottom line is at this point there still is a dearth of research on fathers, and it's not just specific to autism or developmental psychopathology. In other fields as well, the lack of fathers is also something that's discussed and has been noted in areas like pediatric psychology, school psychology. So it's not to say that fathers are entirely absent in the ASD literature. There has been research on fathers. I'm going to talk about that today. However, the vast majority of research that has been conducted with parents of children with autism includes mothers, either exclusively or primarily as the participants. So I'm thinking about, fathers as a group, as a entity, as its own group to be studied. Why study fathers? Why is it important? And in looking at research that has been done on fathers, there's really kind of three main reasons why that is. The first is that we know, based on the research that does exist, is that fathers have different psychological experiences as parents and as partners. So, for example, research has found that fathers use different coping strategies than mothers to manage the stress of parenting a child with autism. So, fathers and mothers have different psychological profiles. The second is that there's a bidirectional influence where one parent's experiences impact the other parent. And for example, research has shown that paternal depression significantly predicts maternal stress. So there's a correlation, there's a relationship between those two variables. And also research has shown that father stress is positively correlated with both maternal anxiety and maternal depression. So by extension, if we understand and can address father psychological experiences and their needs, it can have a positive influence on mother's mental health potentially as well. And then the third reason is that fathers alone are direct and influential contributors to their children's development. And there's been a variety of studies conducted, again, not so much autism specific, but higher levels of father involvement has been shown to be correlated with higher cognitive development. So for example, higher academic achievement, higher social emotional well-being, for example, less depression, fewer conduct problems, and better physical health. So for example, less obesity, less substance abuse in the child. And furthermore, fathers themselves benefit from being more involved with their children. Higher paternal involvement has been associated with higher self-confidence, with higher parenting efficacy, with greater psychosocial maturity, and less substance abuse, so in the father. And this third point is particularly relevant because fathers are increasingly providing childcare and more responsible for their children than perhaps they have been historically, traditionally. And also, as I was saying, one of the points being made in a more recent review of the literature is also just the focus on having both parents be involved, and the benefits of teaching fathers to learn skills that they can use directly with their child. So by not studying fathers, we are excluding a vital piece of information about fathers themselves and families, and not achieving a more accurate and comprehensive picture. This table is a summary. So when I was looking at parent psychological experiences and interested in looking at these different psychological variables, you'll see across the left-hand side, that left column, these are different psychological variables. So I'm going to show you, this is kind of a summary of the research on stress, on depression, marital functioning, and optimism. So I'm just going to briefly highlight some of the main findings in looking at the literature regarding these different variables. And I've divided the research into three categories in terms of the populations being compared. So who was involved in the study? So the first column is technically the second column, but in terms of the groups, is parents of children with autism versus compared to parents of typically developing children. And the second group is parents of children with autism compared to parents of children with other disabilities. So for example, Down syndrome. And then the final column is mothers compared to fathers. And this is specific to just autism research. So mothers of children with autism compared to fathers of children with autism. So we can see, for example, that parents of children with autism report higher levels of stress and depression, you see that noted in red here on the table, than parents of typically developing children. And they also report higher levels of stress, if we look at that middle column, higher levels of stress compared to parents of children with other kinds of disabilities. This also holds when comparing parents, comparing mothers to mothers, and also comparing mothers to fathers. And in fact, there was a review done in 2013 specifically on stress in parents of children with autism compared to other parents. And the authors concluded that the question in these kinds of comparative studies is not whether parents of children with autism experience more parenting stress, but why are these families under more stress, and what are the specific moderators of stress that facilitate family resilience, right? So how do families cope with that in a healthy, in an adaptive way? The research you'll see in some cases I've noted where results are not as clear. So in terms of stress, the research is mixed when comparing mothers to fathers specifically of children with autism. So some show that mothers report higher levels of stress, some show that fathers report higher levels of stress. In depression, so again, as I was saying, mothers report higher levels of depression than fathers of children with autism. Parents of children with autism report higher levels of depression than parents of typically developing children. And then compared to parents of children with other kinds of disabilities, again, it's mixed. So sometimes the results don't sort of show clearly a particular pattern. In marital functioning, only a handful of studies have been conducted and focused more on parents of children with disabilities as a whole, not necessarily autism specific. But in two more recent studies that examined divorce rates in parents of children with autism, they reported contradictory findings. So one found that the prevalence of divorce was significantly higher, almost double, among the parents of children with autism than those in the comparison group, and those were children with no disability. And the other study that was done found that children with autism living that children with autism were not at an increased risk of living in a single parent household. So in one case, it found that there was a higher rate of divorce, and the other, it found no difference in comparing parents of children with autism to other groups. So I found it interesting when I was looking at that research, because certainly something that I hear fairly frequently is people commenting that rates of divorce are higher in parents of children with autism. And there isn't a lot of research out there, but that is not supported clearly at this time in terms of being able to draw those conclusions from the research that does exist. And then no difference in looking at mothers and fathers of children with autism as a group. In the area of autism, as I sort of go down this list, there's less and less research on these particular variables. So in Optimism, there's been very little research in some cases. As you can see, it says no research. And the results are mixed, again, meaning that there's no sort of clear pattern or consistent pattern in looking at what's been concluded. Parental optimism does appear to have effects that extend beyond just the psychological well-being of the parent, him or herself. For example, although it's not specific to autism, Mark Duran conducted a study in early 2000, and it conducted research on how parental optimism or pessimism impacts the development of later challenging behaviors in young children with cognitive and or developmental disabilities. And so it was longitudinal research that he did and examined a number of parental variables that were hypothesized to predict the development of severe behavior problems at a later point. And the best predictor that Mark Durand found in this research was a measure of parental optimism. And specifically, parents who had less confidence in their ability to influence their child's behavior by the time the children were 3 years old, so they were still quite young, were more likely to have children with difficult behaviors later in life. And that's sort of the genesis of his research on positive parenting, if anybody's familiar with that. So parental attribution style is important, and parental optimism can be a protective factor. So that's obviously an area that would benefit from having more research conducted. Okay, so hopefully that gives you kind of a lay of the land and a bit of a summary in terms of these different psychological variables and what the conclusions have been. And given that parenting a child with autism can be a difficult and stressful task, there have been different supports that have been developed to assist parents. And one of these is support groups, which is what I'm going to talk about today. Support groups are defined in different ways in the literature, but for the purposes of my study and the research that I did, the support group was defined as a group in which members gather to share experiences about a similar issue, and the members give and receive information to each other, as well as emotional and social support. The group is led by a professional who facilitates this discussion and focusing on people's personal experiences, their emotional experiences, and so the facilitator is there to really help facilitate the discussion and kind of guide the discussion. Now it occurs to me, I can't remember, I'm trying to think of when I gave my introduction, whether I noted that this was part of my doctoral research that I did for my doctoral degree a few years ago. So if I didn't, I apologize. And in looking at the research that's been conducted on the effects of support groups specifically, there is scant research. So 8 studies. And of those, for parents of children with disabilities other than autism, there are only 4 studies. So that's their lump there is kind of non-ASD, I've called it. And in those studies of the 4, only 2 had fathers as participants. Similarly, there have been a total of 4 studies conducted on support groups for parents of children with autism. And of those 4 studies, a total of 3 fathers participated. 1, 2, 3 in total. That's it. So there's very little research. Furthermore, the research is outdated. Of these 8 studies, 5 were conducted in the 80s and 90s. And most of the measures that they used in these studies were informal measures. So they were developed for the purpose of that study and therefore are not, haven't been sort of scrutinized and researched as valid measures to be used. So they have either no psychometric properties or weak psychometric properties, or the focus was more on qualitative information. So interviewing participants about their experiences and their satisfaction with the group. In the studies for both of the groups, there have been some positive outcomes. So, for example, studies have found lower depression and stress. So parents reporting less depression, lower levels of stress at the end of the group. Other studies have shown no change. And with respect to the qualitative information, when they've interviewed participants about their experience, participants have generally valued the groups and rated them highly. So there is quantitative and qualitative research to suggest that support groups may have some positive benefits, but certainly more and higher quality research is needed. So given all of that, that's kind of the backdrop and the context to my research. And therefore, my objectives in conducting this study was to design and evaluate the impact of a support group for fathers of children with autism using psychometrically sound quantitative measures and a measure of social validity to examine participants' psychological experiences. So to have them participate in a group, to do these assessments, and also to ask them about their experiences. So I'm going to talk about each of these in turn in a moment. There were 6 participants per group for a total of 12 participants. There were 2 groups. And in order to be eligible for the study, participants had to be the father of a child with autism. They had to have good oral and written English language skills because they were required to fill out assessments in English, and they were also required to talk in the group and participate verbally in the support group. They needed to be either married or in a common law relationship, and not to have any significant psychopathology or mental health issues requiring psychotherapy or medication. So in an effort to try and sort of measure the impact or assess the group, it was recruiting those people into the group that were kind of not participating in any other sort of therapy for themselves or taking medication for psychological reasons. This is probably a very teensy tiny table for you. I'm not sure how well you can read it, so I apologize, but I'll just give you a summary of the demographic information presented here. So this is the demographic information for all 12 participants, and I'm just going to highlight a few of the columns. Most of the participants were Caucasian. They identified themselves as being married. Most had college or trade school education. The total number of children per household ranged from 1 to 4, and the number of children with autism per household ranged from 1 to 3. In total, there were 4 females with autism and 13 males with autism, with the children. And for half of the participants, 6 of the 12, they only had children with autism, meaning that they had no non-autistic offspring. So in some cases, it was either one child in one family, all 3 children were on the autism spectrum. So that just kind of highlights a few of the demographic variables of this group. In terms of the measures that were used, so I looked at these different variables, and to measure depression, I used the Beck Depression Inventory 2. For marital adjustment, it was measured using the dyadic adjustment scale. For optimism, was measured using the Life Orientation Test Revised. Parenting stress was measured with the Parenting Stress Index, the 4th edition short form. Coping was measured with the Ways of Coping questionnaire. And then there was a social validity questionnaire that I developed. And that was just mostly open-ended questions, just asking participants about their experience of participating in the support group. The intervention was the support group, and that consisted of 8 weekly 2-hour sessions that were led by me. And that was sort of a decision that had to be made in the course of developing this study. And in the end, we determined that I would be the one to run the group. I have, in addition to, I'm trained as a behavior analyst, and my background is in special education. I also have a master's degree in counseling psychology. And so I had run groups similar to this before in work that I had done. And that previous experience and work actually laid the foundation to then examine this empirically, so to actually conduct a study and research this particular topic. So through different determinations that you make when you're actually conducting research and how to go about it, we decided that I would be the one to lead the groups. And my role as the leader in terms of the style was really to be the facilitator. So to facilitate the discussions amongst the group members, which would be described as a more kind of suggestive or guiding interaction style. It wasn't didactic, so it wasn't having people come in and saying, okay, here's kind of the 10 things I'm going to teach you today. It wasn't a teaching group. So my role was really to help identify themes that were coming up in the discussions and to then help the participants identify them, to name them, to explore them, to talk about their thoughts, their feelings about those different topics, to provide autism resources when it was appropriate, when people were asking for them, and generally making sure that the group was kind of on track and productive and sort of focused on the topic at hand. I'm going to show you a list of the topics. So there was a different topic or theme for each of the 8 weeks. And this is, again, based on work that I had previously done, experience that I had had in running these groups with fathers specifically, and also getting input from people about topics they were interested in discussing. So of the 8 2-hour sessions, so 16 hours in total, there were approximately 2 hours that were spent on members getting to know each other, in the beginning, kind of the meet and greet, and then wrapping up the group and sort of summarizing and finishing things up at the very end. So approximately 14 of the 16 hours could be considered kind of more therapeutic hours. There were 3 sessions, as you can see, that looked at the impact of having a child with autism on different kinds of relationships. So 1 week it was focused on their relationships with coworkers and friends. 1 week it was on relationships with other family members. And 1 week specifically was focused on the relationship with people's spouses, their partners, because obviously such an important person and partner to have that time to talk about that relationship, which is kind of the base of the family and the center of the family. So we spent 1 whole session just talking about that. And then in the end, it sort of moved to looking more to the future, thinking about other lifespan issues, how people kind of conclusions that they were drawing, what they were thinking about after working through these first sort of 6 sessions together, and then kind of a wrap-up, feedback, celebration of fathers at the end. And the session structure was the same for every week. So there'd be a check-in at the beginning where I would talk to the fathers and check in and see how people were doing and any thoughts that people had about the previous week's discussion, thoughts or questions that people had, what they took away from the previous week. Then there would be a focus on the current topic, so we would talk about one of these topics, whatever it was for that particular week, including some specific questions to help guide the conversation, if that was needed, and then a wrap-up and kind of concluding at the end. In terms of the actual design of how I conducted the study, it was 2 groups, as I was saying, so a pre-test, post-test design. The original design was to be able to randomly assign people to groups. And so for people that are familiar with research design, that would be a stronger design to be able to do that. It was kind of a protracted recruitment period in terms of recruiting fathers to participate in the study. And so I didn't really want to wait much longer. And anyways, these are the sort of variables you consider and things you have to figure out as you go along. I would say it's research meets reality. And so the decision was made to proceed with the 12 participants that had agreed to participate. And so the 2 groups were largely determined based on people's geographic location, to try and make the group as accessible as possible so that people could attend. And that ultimately led to not having it be randomly assigned. That was one of the reasons. And the groups ran consecutively. So the first group ran for 8 weeks, then there was a break, or maybe not even, I'm trying to think now, and then we launched into group 2, the second group. So generally, data collection, it was just about having people fill out the measures at the beginning prior to starting the group, so at pre-test, and then they had the 8-week support group, followed by post-test. So again, they sat down at the very last, the end of the 8th session and completed the measures one more time. And group 1 completed the entire set of measures one other time 4 months after their group had ended. So that was the follow-up. I'll talk about that later. In looking at the 2 groups and making decisions about analyzing the data and being able to look at the information I was collecting, I was able to group the participants as one group of 12. So that's how they were analyzed for the purposes of the statistical analyses. Don't worry, I won't get into many details about that. And so there are kind of 3 main research questions which I'm going to go through. I'm going to talk about the question and then the results, and then sort of what we can take from the results for each of them. So the first question, are there significant differences on any of the measures between pre and post support group? So were there any differences from prior to starting the group to after completion of the group? Do we see any differences in the measures that they completed on these different psychological variables? So I'm going to be showing you some different graphs, and just need to get you oriented a little bit to each one. And I'm going to go, each graph represents one of the different variables. So you'll see here, this is looking at participants' depression scores. So this is the Beck Depression Inventory 2. And for each of the graphs, you'll see in orange, or kind of that orangey red color, that bar on the graph represents the pre-test score, so pre-intervention. So prior to, this is what the group scores were, because we're looking at group means. And then post-intervention, post-support group, is in yellow. So again, looking at group means, this is for the group of 12. On the Beck Depression Inventory, lower scores are indicative of less depression. So lower scores are better from a psychological perspective in terms of psychological functioning. And you'll see there's a red line on the graph, and that represents the cutoff for minimal depression, which is a raw score of 13. So the scores can range on the BDI from 0 to 63. So 63 would be severe depression, 0 to 13 is minimal depression. So first of all, the first thing to note is there were no significant differences from pre to post intervention. You'll see the scores are very similar. The group means were very similar, 8.6 compared to 8.4. The total, the raw score means were well within the range of minimal depression. So you see that the cutoff is a raw score of 13. People were scoring at about 8.5, so well below this cutoff of between minimal and mild depression. And in looking at individuals, there was no one person that showed evidence of clinically significant levels of depression at any point during the study. Although there was one father who, upon completion of the studies, his Beck Depression Inventory scores decreased by 14 points from a moderate depression score of 20 to a minimal depression score of 6. Okay, so hopefully that makes sense. Just let you absorb that for a moment. And in looking at why might this be the outcome, right? Questioning, thinking about why these are the results. And again, looking at the literature and what we know from looking at previous research that has been conducted. Participants were interviewed to determine if they had any major mental health issues such as depression. So they were screened for depression prior to the study. So it might be that those who had higher levels of depression would not have been eligible to participate in the study, in the group. And given that the group was well within the range of minimal depression, we saw those scores of 8.5, so well within that 0 to 13 range, there was really little room for change in their depression scores. And if we look at the literature, the rates from this particular study were much lower compared to paternal depression in other studies of fathers of children with autism. So 17%, 30% were reported in some other studies. And the rate of depression in the current study is much lower than the published rates. So depression was essentially non-existent in this particular group of participants. The next graph is showing you the marital adjustment scores. This is the dyadic adjustment scale, the DAS. And again, pre is in this orangey red, post is in yellow. We can see that if we're looking at here the group mean scores, 98.6 compared to 100.3. On the dyadic adjustment scale, higher scores, so different from the BDI, higher scores are better in that they represent greater marital adjustment or greater marital satisfaction. Scores can range from 0 to 151. And the red line on this graph shows the cutoff for what they call poor dyadic adjustment, which is a raw score of 100. So we see that the group means, both pre and post intervention, are right around that 100 cutoff. There were no significant differences, and we can see here on the graph, no significant differences from pre to post intervention. And at both time points, as I said, the cutoff, the mean score is right at the cutoff for poor dyadic adjustment. But there actually was a lot of variability. So looking at individual scores, 6 of the 12, half of the participants, had both pre and post intervention scores that were in sort of what they term normal levels of marital satisfaction. And then the remaining 6 fathers had scores that were between sort of 62 and 100, so more in the poor dyadic adjustment range. And these scores all remain below that threshold of 100 for those 6 fathers, so for the one half of the group. And in thinking again about why might it be, what can we take from this information, and looking at the research and what previous research can tell us or how it might inform this outcome or result. Research on marital satisfaction in couples of children with autism is mixed. Some show less marital satisfaction, some show more or no difference. So the fathers in this study reported, compared to, here I have some numbers, it talks here about Spanier's normative sample. That's just the sample that they used to develop this dyadic adjustment scale. So, and in his sample, the mean was 115. So the fathers in this study reported less dyadic adjustment than the most satisfied couple in Spanier's study of a mean of 115. As you recall in the previous graph, the mean was around 100. But they did report higher levels of dyadic adjustment than the divorced couples in Spanier's sample. So in his research, the mean for divorced couples was 71, or couples that were contemplating divorce, the mean was 85. So the mean scores in this study of 100 were higher than those couples. This graph shows the Optimism score. So this is the life orientation test revised. Pre and post, you see that the mean is exactly the same, the group mean. On the life orientation test, higher scores are indicative of higher levels of optimism. So generally higher is better. And the red line on this score shows the mean for men in the normative sample, so the sample that they used to develop this particular measure, so right at 15. And there were no significant differences. Obviously, the group means are exactly the same from pre to post. Now, in thinking about optimism, and again, what we know based on the literature, optimism is thought to be a trait and has been shown to be stable over time. So perhaps it's not that surprising that optimism scores showed high stability and minimal change. The research on optimism in parents of children with autism is scant and only compares them to parents of children with other disabilities. And in those studies, optimism in primarily mothers, but optimism in parents of children with autism is positively correlated with mental and physical health. It's predictive of fewer child problems. I was talking about the Duran study. And it's certainly an area that warrants further study. More research is definitely needed to find out more specifically about optimism and how that might have a moderating effect, how that might influence parents, and specifically parents and fathers, certainly of children with autism. This graph shows the parenting stress scores. So this is the parenting stress index, the short form. And on the PSI, lower scores represent less parenting stress. So the lower the score is generally better in terms of psychological functioning. The red line on this graph shows the cutoff for clinically significant levels of parenting stress, which is a raw score of 114. So we see here the group means of 100 pre-intervention and 96 post-intervention. There were no significant differences from pre to post. So same as the other slides, no statistically significant differences. Overall, the group means were below this cutoff of clinically significant stress, below this 114 cutoff. And in looking individually at the scores of the fathers, two of the 12 continued to report more elevated parenting stress post-intervention. So they continue to report more clinical levels of stress. And the scores for, 4 of the 12, so a third of the group, scored at or close to clinically significant levels of stress at pre-intervention. So 4 of the 12 were already kind of right at that cutoff point. And then of those 4, 2 of them continued to report more elevated stress levels, whereas the other 2 in that group, they both had fairly substantial reductions in their stress score at the end of the group. So both of their scores had decreased by 22 points at the end. I'm going to show you a different table with that information into more like the what they call the normal range. So again, looking at some of these individuals gives you a different picture, gives you other information. And in going to the literature, certainly more research in looking at psychological variables, more research has been conducted on parenting stress than any of the other psychological variables. The rate of elevated paternal stress in this study, so 33%, 4 of the 12 are reporting more at levels of kind of clinical levels of stress, is comparable to published rates in the autism literature. Although it is lower than a more recent study in 2014 of 118 fathers, reported 60% of those fathers reported clinically significant levels of stress. Other research has shown that stress is fairly stable over time. So in that regard, it is consistent with previous research on parents of children with autism. Okay, and then the final variable is coping. So this graph is a busy one. It shows the scores for the 8 different subscales of the Ways of Coping questionnaire, and it measures coping strategies. I'm not going to go into a detailed analysis of each of those 8 subscales, other than to tell you that there were no significant differences from pre to post intervention. And there were some increases. It measures different kinds of coping. So some of them would be considered more constructive coping strategies. So accepting responsibility, doing some planful problem solving, positive reappraisal of a situation, whereas other coping strategies would be considered less constructive or non-constructive. So more confrontive coping, distancing, escape, avoid. And for 2 of the 3 more constructive subscales, there were slight increases in the mean scores from pre to post intervention. And there were some decreases in mean scores for the non-constructive coping scales. Again, they weren't statistically significant. And in looking at, again, the literature, there were no significant changes on any of the scores over time. But as I was saying, there's some change kind of in the desired direction for 5 of the 8 subscales in total. And one of the points to make is that there wasn't a change in coping, but the focus of the support group was not to teach coping skills. So there weren't coping strategies that were taught in the group, and perhaps that might have been a factor in why there were also no changes in coping over time. Okay, so as I've shown, there were no statistically significant changes from pre to post intervention for any of those different psychological variables. And because it's a group design study, this type of analysis doesn't look at individuals and how those individuals change from pre to post support group. And so it can mask individual changes. And as I've talked about in previous slides, there were changes in individuals over the course of the support group in terms of the measuring, looking at the scores of the measures pre and then post support group. So this table shows individual score changes of 10 or more points in the direction of improved psychological functioning. So in the case of depression, improved psychological functioning would be indicated by lower depression scores. Same for parenting stress. So lower scores over time. And in marital adjustment, higher scores are indicative of higher marital satisfaction. So I went through and I looked at the individual participants in the group and how each of those individual scores change from pre to post intervention for all 12 of the participants. And so we can see here that for one of the participants in group 2, each of these numbers represents one of the participants who had a change of 10 or more points. So I only included those that were more substantial changes. And so we can see that for one of the group members in group 2, he had quite a substantive decrease, reported decreased depression at post-intervention, so by a decrease of 14 points. We see that altogether there were 4 of the 12 participants reported higher levels of marital adjustment at post-support group, so ranging from +10 to +13. And then there were 3 fathers out of the 12 who reported lower parenting stress scores at the end of the group. And there are 2 numbers there in blue you'll see. That's the same father. So the father who reported lower levels of depression also reported lower levels of parenting stress at the end of the group. So 7 of the 12, this represents 7 different individuals, 7 of the 12 participants showed substantial shifts in one, or in the case of one father, and 2 of these variables over the 8-week group, particularly as we see in group 2. So there were individual changes from pre to post support group. And again, doing research as groups and looking at group means, you don't see that when you're reporting just on the group means. Okay, so the second research question was looking at group 1 specifically, and were there any significant differences on any of the measures between pre-intervention and the 4-month follow-up, or between post-intervention and the 4-month follow-up? So I was interested to follow this group and examine the possibility of a change over a longer period of time. And in part because there was previous research that had been conducted, 2 studies in particular, showing evidence of what they would call a sleeper effect at 6 and 12 months post-treatment for those 2 studies. And so there were no significant reductions in participants' distress immediately after the group had concluded, but at a later point, so in the one study 6 months and the other 12 months later, there were significant improvements in psychological functioning. And I wanted to see if that might be the case in this group. So I analyzed that. I followed up with that one group 4 months later. And this graph shows you each of those variables, except for the coping measure. I didn't include it here. So you'll see here to the left, we have the BDI, the Beck Depression Inventory. It shows pre, post, and follow-up. So again, pre and post, same colors, orange, yellow, and then follow-up is there in blue for each of those scales. So the Beck Depression Inventory, the Dyadic Adjustment Scale, the Life Orientation Test, and the Parenting Stress Index. And the red lines that you see show the cutoffs for each of the measures. So again, what were the sort of cutoffs representing a different level of whatever it was, depression, parenting, stress. The overall takeaway is that there wasn't a significant difference for any of these variables from pre to follow-up, so prior to intervention to follow-up, right after the completion of intervention to follow-up. There was no sleeper effect. I didn't find that in this group and in looking at these variables. And the 2 previous studies that had found evidence of a sleeper effect, there were differences in the type of the group that they ran, in the content of the group. So one of the groups was a combination psychoeducational and counseling group, which taught specific behavior management skills over the course of the group in both group and individual format. There was a difference in terms of duration. So the group that I ran was 8 weeks. In the other 2 studies, one was a 20-week group. The other one was a year-long group, 52 weeks. And it was a shorter follow-up period. So I followed them up 4 months later. The other studies examined the same variables at 6 months and then at 12 months. And it may also be that psychological functioning prior to intervention might have played a role, and that significant improvements might have been more evident in individuals who were more distressed prior to treatment. So, for example, in the Tonga study, they found that family functioning significantly improved over time in 33 to 43% of the families who had the highest levels of dysfunction. So it may be that those families who are most in distress and kind of most in need of help benefited the most from that because they were at more of a crisis point or suffering more or having more struggles, more difficulties prior to coming into the group. And then the final research question, what is the social validity of the intervention? So specifically in looking at kind of what did the group mean for the participants? Will the participants attend the support group regularly? Will participants report that the group was helpful? What will they identify as being most helpful? And will they recommend the group to other fathers of children with autism? So this is looking at kind of the group's perceived value and utility to its members. And this graph shows the average number of sessions attended for group 1, group 2, and both groups combined. And the attendance was excellent. Both groups combined attended 94%, so 7.5 of the 8 sessions, which is much higher attendance than in other published research. There was an article by Davison and colleagues in 2000. They talk about the social validity of support groups. And they say that, quote, participation is its own index of success. Groups without value cease to be groups. Members vote with their feet. And so for these two groups, members did vote with their feet, and they attended almost every one of the 8 sessions. And furthermore, both groups spontaneously expressed a desire to continue meeting on a social basis after the group had ended. So they were making connections in the course of being in this group together, and they continued on to meet with each other after the formal group had ended. And they used to CC me on the emails that they were getting together. So whether it was going out for kind of an outing, just the fathers, or meeting for a beer at a pub. They also organized family events, so to bring partners and their children as well. So they connected, and there was a desire to keep meeting outside of the group. And in looking at responses to this open-ended questionnaire asking them about their experience in the group, all participants reported that the group was helpful and would recommend it to other fathers. One father wrote, "I think this type of service would be a tremendous contribution to the autistic community and their families. I honestly feel this type of interaction is as important as an AA group is for an alcoholic." And that father in particular, that was really his first opportunity, had been the first time that he had sat down and talked to other fathers of children with autism, and had a chance to hear from other people and share experiences. So in looking at people's responses, what fathers cited as being most helpful was hearing from and sharing experiences with other men in similar circumstances, being able to talk about issues in a caring, open, and accepting atmosphere, and getting new perspectives, insights, and information on how to parent a child with autism, as well as manage other relationships. So for some people, it certainly seemed to help to counteract some isolation perhaps that they felt, and to be able to talk to other people who just who got it and didn't have to worry about judgment or explaining what their life was like, because they were sitting in a group of men who deeply understood what it meant to parent a child with autism, and being able to identify with other people who had similar experiences. And for some, as I was saying with this one father, for some it was their first opportunity really to sit down and talk with other men about parenting a child with autism. And in one of the groups, there were, in one group, the fathers who had older children took on a role of kind of like elders in the group, where they were able to share their wisdom and their experience with younger fathers, and giving those younger fathers sometimes advice, sometimes reassurance. So it was sort of an unexpected positive benefit too for them to take on that role specifically in the group. This is a quotation that talks about limitations of research, because again, when you conduct research, you have to think about, what could I have done differently? How does this have implications for future research? And so this specific quotation describing limitations of their research on an online parent support group really aptly summarizes some of the challenges that I had in conducting my research. It is difficult to know whether the lack of differences over time was due to relatively high well-being scores among the participants prior to participation in the group, or one of the following possible limitations: small sample size and ineffective intervention, the variables chosen to measure change over time, the measurement tools chosen, or some other problem. Future research with this population should focus on ruling out these potential problems when examining the effectiveness of support groups for parents of children with autism. So was very validating to read that in the midst of conducting all this research and trying to understand, analyze the results. So obviously many things to consider when trying to understand and interpret the results, and I'm just going to highlight a few of those. So the research design was one limitation, obviously, as I've spoken about previously. Originally, the plan was to have random assignment, which would have strengthened the research design, but it wasn't feasible. And so certainly future research could strengthen the design by having a control group, by randomly assigning the participants to groups. In terms of the sample of fathers in the study, it was a small sample size. It was only a group of 12, so that limits the kind of conclusions that you can draw, the analyses that you can do statistically, and the conclusions that you draw from that. And the sample was not representative of the cultural diversity of the population. So where the sample was drawn from, the people that participated, visible minorities make up 38% of the population. But in my sample, my little sample of 12, only 25% were from a visible minority. And then there's also an issue of what we would call self-selection bias. So only certain fathers would choose to participate in such a study. And so in that way, perhaps they're also not representative of the broader, greater population of fathers of children with autism. So those are considerations certainly to think about. A few more limitations just to note. There are numerous variables that relate to design that might have affected the outcomes. So perhaps a longer course of treatment, more group sessions, more than 8, would have yielded more changes in fathers' well-being, or perhaps longer sessions or more frequent sessions would have had a different effect. A different type of group, possibly, such as a group focused on teaching specific skills, so stress management might have resulted in different outcomes. So again, these are areas for future research to investigate. And although I made a point in using measures that were had been validated empirically and that were psychometrically strong, there may have been measurement issues. Really, it's about were the measures that you use, are they sensitive and specific enough to detect changes and to measure the thing that you're trying to measure. So there may have been that using other measures might have detected more subtle changes or differences. All of the measures were self-report, which means that you're relying on participants to report and be truthful, hopefully truthful and accurate about their psychological experiences. Related to this is an issue in research, it's called reactivity. So social desirability, for example, sometimes people might feel like they need to respond in ways that show them as functioning better, potentially, that they're respond in a way that they deem to be more socially acceptable, so they may not be entirely truthful or accurate in their responding. People may have also reacted differently because they knew that it was my PhD research. And also I was the only woman in a group of men, although I did look at the literature on that to see whether therapist gender has an effect, and it has not been shown. And they've done meta-analyses, so they've done quite substantial research on it, and therapist gender does not predict client outcomes, but it's something, of course, to note. So these are all areas for future research to explore and ways that the current study could have been altered and strengthened. But in conclusion, this exploratory study was the first to examine the impact of a support group for fathers of children with autism using quantitative measures to assess psychological functioning and experiences pre- and post-intervention, and also using a measure of social validity to assess the group's usefulness and its value to its members. There were no statistically significant group changes observed in people's well-being. However, there were changes in individual scores, which indicated improved psychological functioning. And the group was perceived as valuable and worthwhile, and fathers did recommend it highly. So certainly there's lots of other avenues, areas to explore in future research. The bottom line, based on previous research, on my research, the current status is that more research on fathers is needed. And sadly, the vast majority of research still focuses on mothers, either exclusively or primarily as participants. And from an empirical perspective, conducting more research on fathers gives us really important information about fathers' unique experiences and their contributions, and how these are different from or similar to mothers. And in terms of the clinical perspective, as service providers, the information can help support and assist fathers to be better parents and partners. So it helps us as clinicians to work with those families to develop interventions that are going to be beneficial to fathers, to mothers, to the family, hopefully, as a whole. Thank you for listening. And I'm happy to take any